Hello, it's Dr. DeShavo, and we are back with the second part of PATH, Chapter 12, Musculoskeletal Function. We're diving into joints. So these joints will connect bones of the skeleton. And we're going to talk a little bit of each, but we already explained the ends of long bones, and I gave you a general once-over about synovial joints. So those synovial joints are going to have the two ends of the long bones with the cartilage on the end and the synovial membrane containing what's called synovium, which is that viscous fluid, or synovial fluid is fine, that's in those joints. And it helps to fight infections and deliver nutrients to the cartilage, but it also lubricates and protects the joints themselves. Because don't forget, where synovial joints are, there's a lot of movement. And with a lot of movement comes a lot of stress to a joint. So there's that joint capsule on the outside, which is an irregular connective tissue that helps to connect one bone to another, but it also forms the barrier or the protection for the inside of that joint. It molds right into that periosteum, which is that outer covering of the bones that I showed you in the earlier picture. And it also may have ligaments around it to help to provide support. And ligaments, once again, connect bone to bone. Excuse me. We also have joints which are not as movable as those synovial joints. They're put into areas where we have more support but less movement. For example, the vertebral column has what are called amphiarthroses. And amphiarthroses are slightly movable, but not as movable as a synovial joint or the next joint known as a synarthroses. So, for example, we can find an amphiarthrosis in the vertebral column. That's as far as we're going to go with those. Generally, they're the areas where discs are. Pubic symphysis, vertebral column, for example. Those would be the only examples that I would give to you. Synarthroses are movable. These are going, pubic symphysis, I disagree with that. Anyway, all right, well, we'll just keep it to one example. Okay, sorry, your book and I disagree at times. So we're going to give you one example to keep it simple. Amphiarthroses will keep as slightly movable, found in the vertebral column. Synarthroses are movable. And for example, we have the sutures in the skull. So those are bones that fuse together as a child matures into adulthood to form that nice, solid skull. So let's practice some of these. Okay. Types of joints. So out of the joints that we just spoke about, this one's going to obviously be a synovial joint. And this is your hip, that ball and socket joint. And I just want to point out all the structures that we've spoken about. So you have that joint capsule, which will be on both sides and all the way around the joint, you understand. And it creates a nice protective, dense, irregular connective around the joint, connective tissue around the joint, in order to keep the synovial fluid and the synovium, which is the inner layer on the inside of this joint capsule, protected. You also have that hyaline cartilage on the ends. That's a type of cartilage. Some people call it articular cartilage because it articulates in that joint. You have the synovial cavity, which will have synovial fluid in it to lubricate and protect that joint and bring it nutrients. If you look at it from the outside, there are several ligaments between the pelvis and the femur to support the femur, because the femur takes so much stress and that joint takes stress, and the bony pelvis takes stress since we walk so much. So that was a little bit of a let's practice and a little bit of talking. So I'll stop talking and move on. Okay, next one. What type of joint is this? Slightly movable or amphiarthrosis. This will be found in the intervertebral discs in the spine. You can see them here, and those discs go between the vertebrae. And the way that those discs are structured is you have a hard cartilaginous outer portion, and you have a gelatinous inner portion. And the only reason I bring that up is because it's like a really, really hard jelly donut. So when we herniate a disc, the jelly center of these discs pops out and provides a herniation. Generally, where they like to herniate is back into the nerves that come out between each vertebra, and we get pinched nerves. Now the last one. Okay, so let's talk sutures, because I told you I would narrow that down. This would be, and try to remember the name. If you need to pause it, go ahead. This would be an immovable joint. This would be a synarthrosis. The reason I don't say pubic symphysis is because with birth in a female, you can actually loosen that a little bit and can widen the pelvis. So we're splitting hairs here, but that's why we're going to go with synarthrosis. And you can see while we're here, first of all, with bones other than long bones, we could have spongy and compact bone. All bones will have a layer of compact on the outside and spongy in the middle. You can also see the frontal bone here, parietal bone here, temporal bone here, and all the way through here because it encompasses the ear, occipital bone here, mandible, maxilla. Oop, and I went a little bit into zygomatic. Maxilla is actually right here with the teeth. On the bony pelvis, you have your ilium up here, your ischium are the bones you sit on, and the pubic bone is the one in the front. And what happens is they all fuse together, and you can see the three separate bones in the acetabulum, which is the area that the head of the femur sits into. My word, I could talk to you for hours about bones. I love bones. They're so fun. Okay, but we're going to stop talking about bones and joints and move into muscles. Once again, if you want to watch my A&P videos, you're more than welcome. But because we have so much to cover, and also I think a lot of the A&P should be reviewed for you, we got to move forward. What a bummer. All right, so muscles, how strong. Basic muscles I want you to review. Okay, so very basic muscles. We have pec major, pec minor, which are going to be your pec muscles. Major sits on top of minor and is much broader, comes all the way through the chest and attaches out to the arm. Your trapezius is your big, broad back muscle. That's actually the majority of the back muscle here. Your deltoid, you guys know, because you can do injections there. That's where I go and get my immune shot injections every week. Your biceps, you know as well, which is going to be in the front. That flexes the arm. The quads are made up of 4 separate muscles. We're just going to go with quads for now. Vastus lateralis, you probably know from injections, though. Achilles tendon goes into the heel, and that'll attach up to your calf muscles, which is your gastroc and your soleus. I didn't highlight it, though. The ones that are highlighted, you need to know. Gluteus maximus is that, I hate to say butt, that big butt muscle, right? Maximus. Rotator cuff or shoulder girdle. Everyone calls it rotator cuff. What did I just say? Rotator cuff. Okay, that's going to be 4 muscles that rotate the arm. The reason it's important to know that is because people can tear their rotator cuff. It consists of 4 your sit muscles. If you're interested, go look them up. Supraspinatus, infraspinatus, teres minor, and subscapularis. But you just need to know rotator cuff, and those are the 4 muscles that rotate the arm. Triceps, you should know. Your nice strong triceps prevent the bingo wings, right? The stronger your triceps are on the back, I always joke because I have bingo wings. I've got, excess skin hanging down there. But strengthen those up and you'll have tighter triceps. Gluteus medius is the small butt muscle, and your hamstrings are the back of the upper legs. Okay, and your hamstrings you can actually do reflexing. But anyway, whatever is yellow you need to know. You should already know a bunch of it, hopefully. So hopefully this is review for you. All right, so we have over 600 skeletal muscles that are controlled by the brain. Your book has like 300, it's 600. So these are voluntary muscles that connect to the bone, and these are the ones that we have voluntary control over. Smooth muscle are involuntary. They line the walls of hollow organs and tubes. And cardiac muscle is involuntary muscle that is in the heart. The reason they're all different is they have different microscopic attributes that we're really not going to get into, but they also are different because skeletal is voluntary, cardiac and smooth are not. So there's different reasons that there's 3 different named muscles. Those are just 2 examples. Now, we went over the innervation of skeletal muscles in neurology, but just a quick review with the skeletal muscles. You're going to have that action potential come down, the axon of the nerve going to the muscle. It'll release calcium at the end of that axon. The calcium releases acetylcholine. Acetylcholine is the neurotransmitter that we need in order to trigger a signal to a voluntary skeletal muscle. Acetylcholine releases. It'll go into the synaptic cleft. It'll attach to receptors on the skeletal muscle. And what happens then is that skeletal muscle will cause, or that acetylcholine will cause the skeletal muscle to have an action potential. So basically, it's action potential, acetylcholine is a neurotransmitter, action potential in the muscle fiber. There's a lot more than what I just explained. Okay, those are the basics that I want you to know. Okay. And of course, if you have any questions about that, let me know. Now, the basics of muscle fibers, and once again, I'm not going to get a ton into this because we've got to get into the pathologies. With the muscle fibers, if we look at the whole muscle, and that muscle attaches to a tendon, and the tendon attaches to a bone, just as a sidebar. If we look at just the muscle itself, here's a bunch of muscle fibers. If we look at a single muscle fiber, known as a myofibril, it's made up of actin and myosin. So actin is known as thin, myosin is known as thick. And once again, there's a ton more. I just want you to know these basics. So what happens with the muscular contraction is these actin and myosin fibers slide across each other. And you can actually see actin will slide in both sides of myosin. Myosin basically has little arms that it grabs onto the actin and pulls that actin in. And what that does is it shortens the entire length of a muscle fiber. If you imagine millions of these actin and myosin myofilaments or filaments in the muscle, and they all shorten, you'll shorten the muscle. Once you're done with that movement, they relax, and those little cross hinges from myosin will actually allow the actin to slide back out. Okay, so that is the very basics of how muscles contract. There's a ton more, but as long as you know these basics, you know, the muscle and the tendons, you know, I just like that because I like the picture. The tendon has nothing to do with the shortening, it just attaches to the bone. But if we look at a bunch of muscle fibers and then just a single muscle fiber and then a single myofibril, and you understand the myofibril makes up the single muscle fiber, makes up the bundle, makes up the muscle. And in that myofibril is the actin and the myosin. Actin is thin, myosin is thick, and myosin has little hinges that attach to the actin. When the muscle contracts, those hinges pull the actin fibers in, shortening the entire length of the muscle. Hopefully that makes sense. And once again, if you've studied it recently, there's a ton more, but I'm just trying to give you a general working knowledge of that. And then that'll strengthen or shorten the full length of that muscle. Okay, so ligaments connect bone to bone, tendons are muscle to bone. Just a side note, and this, once I say it, you're going to be like, oh, this makes sense. Muscles and tendons have to cross a joint in order to move the next bone. Okay, so you can't connect your biceps from humerus to humerus, won't do anything. You have to connect it partially from humerus, partially scapula, but down to the radius so it can move the forearm. So just something to note. So moving into musculoskeletal conditions, we're moving right along here. I broke what? My kids have broken so much and strained so much. I could probably tell you about every fracture possible. But anyway, okay, fractures are easy. But obviously musculoskeletal conditions can cause a lot of issues. Chronic pain, injury, impaired physical mobility, self-care deficit, congenital, and the different types we're going to move into. There's congenital, traumatic, metabolic, something's wrong with their metabolism, inflammation, which is probably the one that sounds most familiar to you guys, chronic issues, and bone tumors. We're going to run through most of these. So let's look at structural/congenital. These can be things that you can be born with. You can also develop these over time. So a kyphosis. Let me see if I have, I have a let's practice. Okay, great. So kyphosis is an increased curvature of the thoracic spine posteriorly. So it's that hunchback appearance that people can get. You can develop it in adolescence, but more often we will see this in older people due to osteoporosis. What happens with osteoporosis and kyphosis is if we look at the nice squares of the vertebra, it's as square as I can get it. I know it's not perfect. And if this is the spinous process, and then we have the area where the spinal cord is here, and then we have the vertebra here. What happens with osteoporosis is the front part of the vertebra compresses. I don't know if that draws it well enough. Let me draw it a lot bigger. So if we have the square of the vertebra, yep, that's better. And here's the spinous process in the back, and the spinal cord would be right behind the vertebra. There. What happens in osteoporosis is the anterior part of the vertebra starts to compress with osteoporosis. This back part of the vertebra usually maintains its height because it has other structures helping it to stay strong. So with osteoporosis, if you imagine every vertebra decreasing in height in the front, they tend to appear hunchbacked because every one of those creates a bigger C-shaped curve in the back of their spine. You can just develop this congenitally as well. Excuse me. So kyphosis. So this will be an increased curve in the thoracic spine. This is compared to lordosis, which is an exaggerated concave curve of the lumbar spine. So it's when the lumbar spine hyperextends. We'll see this and as soon as I give this example, you'll understand. Gymnasts, they have that really increased frontward curve or concave curve of the lumbar spine because they hyperextend their lumbar spine so often. So they're prone to fractures in their lumbar vertebra if they keep over exaggerating that lumbar curve. So this could be in adolescence. We'll also see this with extreme truncal obesity, overextension. It would be hyperextension. I think I was saying flexion. I apologize. Hyperextension of the lumbar spine. And pregnancy. Because of the weight gain with pregnancy, it'll pull the low back forward and cause that hyperextension. So let's practice. So these obviously will be changes of the spine. Normal is on the left. Middle would be which one of the two that we spoke about? You're like, got it, kyphosis. And you can see on this picture the vertebra. And if you imagine in the thoracic spine, if each one of the anterior parts of these vertebrae were to decrease in height, they will start to increase that C shape of the thoracic spine. Now the last one should be easy. That's going to be, try to stay in your head, lordosis. And you can see there's an increase in the curve of the low back forward. So if you were to imagine in pregnancy, I definitely had this with pregnancy. With my first, then I put on almost 40 or 50 pounds, like almost entirely in my belly. He was huge. So that pulls on the lumbar spine forward. And that, again, would be lordosis. Now, the next one is scoliosis. So rather than looking at the patients from the side, we would look at them from the back or front. And it would be a lateral deviation of the spine. It usually will affect both thoracic and lumbar. The vertebra, because of the stress of them going in that lateral deviation, can actually rotate as well. They could have an associated kyphosis or lordosis just because of the rotation of the vertebra and that lateral movement of the spine. This could be really mild. I have a very mild lordosis or scoliosis. I know somebody very close to me that has between 20 and 30 degree scoliosis. The problem with scoliosis, if it gets too great above, I believe, 40 degrees variation, I think maybe between 30 and 40, I forget the exact number, it can start to affect the heart and also your ability to breathe because it'll affect your lungs as well. So once again, with all these causes they list, I won't ask you them specifically. I want you to derive complications from what we spoke about. You know, obviously chronic spine, they're going to have arthritis of the spine, probably pressure on those discs. But causes, there's a ton of those listed. Usually people are just born with it. So if I were to focus on one of those, I would say idiopathic. Here's a picture of scoliosis, and you could see the varying degrees. So here, excuse me, here's normal. Here's a mild deviation, such as I have, and this would be somebody who's probably into 30, 40 degree variation, lateral variation. And what happens is with them, when they bend forward, and you all know this, you're going to see those ribs humping up to the side. And that's because with that lateral deviation, the vertebra can only go so far before they start to rotate. And they'll rotate, bringing the ribs back on one side and the ribs forward on the other. And this puts stress on the vertebra. You can get a wedged vertebra. You can get fusion after a long, long time of the vertebra. And you can get fused and connected ribs if you have a large scoliosis. They have lots of ways you can treat this now. So this is something that, of course, we screen for early and try to get youngsters into exercise and bracing if they need it. Let's look at some fractures, okay? Obviously, you've all seen these, so let's rock through these. A simple fracture is going to be when it maintains its alignment and position. And of course, it's very important for us to know if it's aligned in position, because then it can heal really well, because those bones are vascular and they heal great if they're in the right place. If they're not, as you probably know, first of all, if they're exposed, that's obviously going to be a surgical issue. But if they're not aligned, even if they're not an open fracture, they won't heal correctly. And we all know this. So Just nomenclature, transverse will be straight across, oblique will be at an angle, and spiral will usually be a twist around those bone shafts. And those are always a little bit of a red flag in young kids. You got it, because they might be getting their arms twisted. Comminuted fracture means multiple fracture lines and bone pieces. These people are going for surgery. They need to get everything put back together. Green stick fracture is an incomplete break in the bone. When it's bent, only used on the outer, usually on the outer curve of that bone. This is common in children because they don't have fully ossified bones yet. So it looks just like a green stick that's not mature. If you try to break a green stick, usually the outer portion will start to fracture open, but you can't fully break it. That's what happens in young children with this green stick fracture. Compression fractures, I guarantee you've seen and or will see. The bone is crushed and collapses into small pieces. We quite often see this in vertebra. Complete fracture is when the bone is broken into 2 or more separate pieces. Incomplete, it's not. Open or compound fracture, the skin is broken and bone fragments or edges are out. You know all this. I'm zipping through it for this reason. And then closed will be when the skin is intact. Doesn't mean that it's looking great in there. Just means it hasn't made it through the skin. Impacted fracture is when one end is forced into the other. I don't think I'd ever ask you that. Pathological fracture, you should know. This is going to be a weakness generally from some sort of metastases. So if somebody has had a fracture that came on quickly and easily, you really want to make sure you're looking really closely at those x-rays to see if there is any metastases in the area. They might want to get a bone scan. This also could happen with osteoporosis. Now, a stress fracture is going to happen with repeated stress. We see this with athletes, people who love to run and run and run and run and run. It's not me, by the way. Run and run and run can get these stress fractures. They're usually small and will heal well. The problem or issue with that is they're an athletes. They want to get back out and exercise again. So you have to watch these people pretty carefully. Depressed fracture, I always think this is when somebody gets really mad at another person and bangs them on the head. It's got to be some sort of severe trauma that is very localized and is forced inward. And this could happen in the brain, like I said, if somebody gets hit with something hard, but this could also happen in accidents. Here's different examples of fractures. Look, this is what your book gave us. Look at that one on the left. Oh my goodness. And you can see it on the right here as well in the mid tibia. So let's do a quick let's practice and then we're going to get on to the next video. So let's look at these, and you can pause the tape and then I'll reveal them and we'll review them. And let's really try to practice these and list them. And if we look at these, so A is transverse, which is because it's across. Oblique is B, which is at an angle. C is a really good spiral fracture. I don't think we quite always see it go all the way around. I guess you could. D is comminuted. There's multiple pieces. E is that green stick. You can see it's only fractured on the one side. The rest of the bone is intact. And, oh, that was E. I apologize. I think I said D. F is a compression fracture of the vertebral body. And you could see what happens in that front part of the vertebral body. Lots of fractures. All right, we're going to move on to the next video. Once again, thank you so much, and I will see you in the next video. If you have any questions, as always, give me a call, an email. Thank you very much. This is Dr. DeShavo.